lecture, that is Arachnoid Hemorrhage 10 Principles of Management by Dr. Shiv Kumar. Please, sir.
Good evening. Greetings from Coimbatore and greetings from my institution, Royal Care Super Speciality Hospital. Let me start by acknowledging my teachers who taught me anesthesia and critical care medicine. And I'd also like to thank all my good friends in Hyderabad ISCCM for this wonderful opportunity. This is my topic, and I assure you I'll be discussing more than 10 principles during the course of my talk. And my talk will focus mainly on these acute care settings and the management of early brain injury, which includes diagnosis of the aneurysm and prevention of a rebleed and treating hydrocephalus and seizures. And it also will include, thank you. And also this will include the delayed treatment like delayed cerebral ischemia and management of medical complications. So majority of my talk will be from this paper in 2023 from AHA and ASA. To start with, the systems of care in patients with aneurysmal subarachnoid hemorrhage, these patients should be taken care of in a dedicated neurocritical care units, and it should have a multidisciplinary team which includes a neurovascular surgeon and an interventional neuroradiologist, and probably this center should be a high volume center. The high volume center they define by if they handle about 35 cases per annum, they define it as a high volume center. Moving on to the diagnosis of subarachnoid hemorrhage, and in patients who are with severe symptomatic headache, they should be evaluated to rule in or rule out subarachnoid hemorrhage, and the factors you take into consideration for this are the time onset from which they present to you and the presence or absence of neurological deficit. Though these factors you take into consideration for further evaluation, and there is a whatever rule at which I will be discussing in the subsequent slides. So usually these headaches are sudden onset and they reach a maximal intensity, and about 1/3 of them they do have a preceding sentinel headache. And as you all know, these misdiagnosis or delayed diagnosis could be a catastrophe, and non-contrast CT scan is the mainstay of SAH diagnosis. So this is a, do you have a pointer? So this is the pointer. Yeah. Thank you. Thank you. So this is the diagnostic algorithm we do use in patients with subarachnoid hemorrhage. So when you have someone with a severe acute onset headache, so you can apply whatever scale. Probably I will discuss in the subsequent slide. So the factors to take into consideration are how early they present to you and whether they do have a neurological deficit or not. Suppose they present to you within 6 hours and they don't have a neurological deficit, you subject them to a non-contrast CT, and if it is positive for a subarachnoid hemorrhage, you can evaluate further either with a CT angiogram or a DSA. In case these patients present after 6 hours and they do have a neurological deficit, they should be subjected to a non-contrast CT, and if it is negative, they should undergo a lumbar puncture, and if lumbar puncture is positive for xanthochromia, they will undergo a CT angiogram or a diagnostic subtraction angiography. This is the diagnostic algorithm which is recommended in these patients with subarachnoid hemorrhage. So this is whatever SAH rule is nothing but a severity risk prediction tool, and this is used in individuals who are more than 15 years who present with the sudden onset non-traumatic severe headache, and if they have any of these following criteria, probably they should undergo an evaluation for subarachnoid hemorrhage. So it's a simple tool in patients with sudden onset traumatic headache, and if they have any of these criteria, they should be subjected to further SAH evaluation, and this is quite useful, and this helps in appropriate resource utilization and prevents unnecessary radiation exposure. This is a review which was done in about close to 1,000 patients, and what they looked at was in patient presenting with severe headache to emergency department, and if the initial non-contrast CT is negative, they did a lumbar puncture, and if the xanthochromia is present, this is associated with high sensitivity and sensitivity for the diagnosis of subarachnoid hemorrhage. This paper looked at the sensitivity of diagnosing subarachnoid hemorrhage from a non-contrast CT. This again patient presenting to ER with sudden onset severe headache, and if you do a non-contrast CT in patients with good clinical grade of subarachnoid hemorrhage who are presenting early and who don't have a neurological deficit, if this is negative and you can categorically rule out a subarachnoid hemorrhage, what you will be missing out will be only a small minority of patients with subarachnoid hemorrhage you will be missing. But the word of caution here is if they have an atypical presentation, probably these patients should be subjected for subsequent evaluations. Coming to the further evaluation for the cause of subarachnoid hemorrhage, in these patients with subarachnoid hemorrhage who are suspicious of aneurysm, if CT angiogram is negative, they should be subjected to DSA. Even if CT angiogram is positive, many of these patients may need a DSA for further treatment planning. Certain hemorrhagic patterns are very typical of aneurysmal subarachnoid hemorrhage, like if they have a diffuse basal cistine bleed or a Sylvian Fisher SAH, they are very classical of a aneurysmal subarachnoid hemorrhage, and any diffuse subarachnoid hemorrhage, irrespective of your CT angiogram, they need a DSA. Coming to how do you prevent a rebleed? I think this is very important. And in patients with subarachnoid hemorrhage, if they develop rebleed, it is associated with major morbidity and mortality. And the ways in which you could prevent rebleed are by appropriately managing the blood pressure and reversing the anticoagulation very early if these patients are on, and use of antifibrinolytic drug. So with regard to antihypertension, you need to be very cautious. You need to use drugs which are act by intravenous route, and you should avoid hypertension or wider fluctuations in blood pressure. With regard to reversal of anticoagulation, if these patients are on, try to reverse this anticoagulation at the earliest. There is no clear-cut recommendations for reversal of anticoagulations in patients with subarachnoid hemorrhage. What is been applicable for patients with ICH can be extrapolated to patients with subarachnoid hemorrhage. And with regard to early administration of antifibrinolytic, though there is a physiological rationale, these effects are not consistent among trials, and there is no major improvement in functional outcomes. So I think randomly subjecting all these patients to antifibrinolytic therapy is not recommended. As far as blood pressure reduction in patients with aneurysmal subarachnoid hemorrhage is concerned, you need to reduce the blood pressure if the blood pressure is more than 180 millimeters of mercury. And when you try to reduce this blood pressure, probably have a close look at the clinical status of the patient, and try to be careful not to reduce the mean arterial pressure less than 65 millimeters of mercury. The factors to take into consideration when you reduce the blood pressure are their premorbid status, the blood pressure at presentation, and the presence of hydrocephalus or the renal impairment. So these factors need to be taken into consideration when you reduce the blood pressure. This is a randomized control trial from Netherlands, and probably they looked at patients with subarachnoid hemorrhage who present to you within 24 hours, and they try to administer tranexamic acid on admission 1 gram, and probably they follow it up with another gram over 8 hours, and they looked at MRS score at the end of 6 months, and they did not find any difference in patients who had a tranexamic acid with regard to MRS scale. Coming to the treatment of ruptured cerebral aneurysms, to start with timing, these patients need to be treated at the earliest possible time window, preferably within the 24 hours time window. And with regard to treatment goal, I think the large of emphasis has been given to complete obliteration of the aneurysm. I think that is very, very important. Whenever you try to treat this patient, you should aim for a complete obliteration. But in case the complete obliteration is not possible, probably if you partially obliterate the aneurysm, and whenever there is a good functional improvement, probably you should subject these patients for a complete obliteration. With regard to the modality of treatment, I think we have been arguing against coiling and clipping, but there is a certain bit of clarity and a stronger recommendation favoring coiling if the aneurysm is from a posterior circulation. And with regard to an associated intracerebral hemorrhage in patients with subarachnoid hemorrhage, this should be decompressed at the earliest time window. I will be discussing it in subsequent slides. And in patients more than 70 years of age, probably we have been always favoring coiling, but this guidelines give a moderate recommendations to say that there is no clear-cut evidence to favor coiling in patients at age group of more than 70 years of age. But in patients less than 40 years of age, these guidelines give a weaker recommendations favoring clipping over coiling with regard to the improved durability of treatment and outcome. I think this is a slight change in the way the guidelines have been. So in less than 40 years of age, there has been a recommendations toward clipping rather than coiling. And one, I think throughout the guidelines, there has been a lot of emphasis to evaluate these patients by a multidisciplinary team, which has a neurovascular surgeon and an interventional neuroradiologist to weigh the risk benefit and try to individualize the decision based on the type of aneurysm. Moving on to patients with good grade of aneurysm with from the anterior circulation, I think who could be a candidate for both clipping and coiling. I think the guidelines recommend there is a good functional outcome at the end of an year. But if you follow up this patient, if you look at subsequent outcomes at 3 years or 6 years, I think both the outcomes with clipping or coiling are equivalent. I think this is something to make a note of. With regard to patients who have subarachnoid hemorrhage and an associated intracerebral hemorrhage, in this paper, if they try to evacuate early, if the clot volume is more than 50 ml, and when they try to do so, it is associated with better outcomes. But if the clot volume is less than 30 ml, they try to secure the aneurysm, and subsequently they try to evacuate the ICH. This is another prospective control trial, and where they looked at the treatment of sacral aneurysms, and they followed these patients for 10 years. And what they found was the first year they found that the outcomes were better with coiling, and subsequently when they followed up this patient at 3 years, at 6-year interval, the outcomes of both coiling and clipping were equivalent. In fact, the risk of seizures and probably the risk of rebleed were more in coiling patients compared to clipping patients. Moving on to the other adjuvants, and there are certain types of aneurysm anatomy where probably you need to use this endovascular adjuvants, like if you have a blister aneurysm, or probably if you have an aneurysm with wide neck, probably you need to use one of these endovascular adjuvants. This could be a flow diverter or probably a stent assisted coiling. So in these anatomies, you need to go for these kinds of endovascular adjuvants. But they also say that, but if you have a different types of anatomy, like where sacral aneurysms, where you could do a coiling or clipping, and if you subject them to flow diverter, probably you will be doing harm. So the anatomy of the aneurysm is important, where you will do a flow diverter. The blister aneurysm is one type of aneurysm where it is very challenging to treat. The options are surgical wrapping or an extracranial and intracranial bypass. And the flow diverter in this group of aneurysm is associated with comparable results. So when you use a flow diverter, these patients are very thrombogenic, and probably you need to put them on dual antiplatelet therapy. When these patients are subjected to subsequent EVDs, there is associated bleeding risk. So whenever you decide on flow diverters, I think there has to be a justification in terms of the type of anatomy where you will use flow diverters, because it is associated with higher rate of complications. Moving on to the medical complications, I think there are any number of complications associated with patients with subarachnoid hemorrhage, and these complications are associated with poorer outcomes, and these complications need to be identified early and treated early. To start with, as far as the ventilation is concerned, standard protocols will apply. If your patient has ARDS and if you have to use a rescue therapy or a recruitment maneuver, these guidelines recommend to monitor ICP. As far as hemodynamics and volume status management is concerned, they do recommend euvolemia, and if you try to augment the volume status, probably it is associated with the poorer outcomes. And glycemic control, they do recommend an optimal glycemic control, and they recommend to avoid wider fluctuations and hypoglycemia. And as far as the DVT prophylaxis is concerned, you need to start these patients with pharmacological prophylaxis at the earliest possible time window as soon as you secure these aneurysms. Moving on to the detection of vasospasm or delayed cerebral ischemia, there could be various modalities which could be used. You can use a CT angiogram or a CT perfusion, continuous EEG, or a transcranial Doppler. Any of these modalities in single or in toto can be used to diagnose vasospasm and delayed cerebral ischemia. Though clinical examination could be useful, but this will have a limited value in patients with severe subarachnoid hemorrhage. The CT angiogram is associated with high sensitivity in patients with vasospasm, but if you have to diagnose as vasospasm in distal vasculature, probably the CT angiogram will not be very useful. CT perfusion will detect abnormalities in microcirculation, whereas CT angiogram will detect abnormalities in macrocirculation. And as far as the TCD is concerned, it is a simple non-invasive tool which you can have a repetitive measurements, and probably you can assess the vasospasm in a dynamic manner, and you could use this TCD with along with other tools. But the limitation with TCD are in certain aneurysms you will be having difficulty in getting good acoustic windows, and probably there is a lot of inter-observer variability, and it will also vary based on your physiological parameters like heart rate or blood pressure. Moving on to the management of vasospasm or delayed cerebral ischemia is concerned, they do give a strong recommendation for oral nimodipine in prevention of vasospasm and DCI. The guidelines give a weaker recommendation for evolemia in preventing cerebral vasospasm and delayed cerebral ischemia. If the patient develops severe vasospasm and progressing to delayed cerebral ischemia, the probable tools are like probably you can use an intra-arterial vasodilator, or you can subject these patients to a angioplasty. And they do give a weaker recommendation for hemodynamic augmentation in these patients with severe vasospasm, and this will prevent the patient progressing into severe delayed cerebral ischemia. And probably we need to make a note, we do use magnesium and statins on a regular basis in patients with subarachnoid hemorrhage, but the guidelines do not offer any benefit for both these agents, both magnesium and statins. And if you try to use hemodynamic augmentation as a prophylactic measure to prevent vasospasm, it is associated with harm. The hemodynamic augmentation should be used only as a treatment of vasospasm and delayed cerebral ischemia. This should not be used in prophylaxis. So nimodipine, the oral nimodipine we use is based on a very old data. There are limited data available for recommending intravenous or intra-arterial use of nimodipine. There is only one randomized control trial which has been done on hemodynamic augmentation, but that does not demonstrate any benefit. There are some smaller subsequent studies which are done on hemodynamic augmentation which demonstrates some benefit, and papaverine is avoided due to the concern of neurotoxicity, and hypotension and elevation of ICP are concerns with intra-arterial nimodipine. And the role of milrinone, I think we have been using milrinone to a larger extent to augment cardiac output. If we have to use milrinone for prevention of delayed cerebral ischemia, probably I think this is not the right time to do that. We have discussed this. And over years, I think we've got a better physiological understanding about cerebral vasospasm and delayed cerebral ischemia. It is not just a anatomical problem of just vasospasm alone. There are multiple mechanisms involved with delayed cerebral ischemia, including a disruption of blood-brain barrier, failure of autoregulation, microthrombosis, and ischemia. Last few things. So if these patients with unreversible subarachnoid hemorrhage develop an acute symptomatic hydrocephalus, they should be subjected to a ventricular drainage or a lumbar puncture. And if these patients have a ventricular catheter, you should have a catheter care bundle similar to what you use with the central venous catheter to prevent these catheter associated infections. And if these hydrocephalus becomes chronic, they will need a kind of shunt procedures. And there are certain papers which have looked at the fenestration of lamina terminalis as a measure to reduce the need for shunt, but that has not been found to be useful. These are the various components of a EVD care bundle, which is being recommended by this guideline, which has got components related to insertion, management, and monitoring. One of the things which they do recommend is a antibiotic impregnated catheter, ventricular catheters, which is associated with reduced rate of ventricular associated infection. Sorry, sir, I think I didn't realize I have gone past. I will finish it. So the last one is with regard to anti-seizure medication. There are a group of patients who are associated with high risks for seizures, like higher grades of aneurysm, who have got cortical infarcts, who got hydrocephalus. So these group of patients are associated with higher risk of seizures. They need to be put on prophylaxis and they need to have a continuous EEG monitoring. There is no benefit of doing a continuous EEG monitoring or giving a prophylaxis in other group of patient. And the guideline also say give a strong recommendation with regarding harm with regard to usage of phenytoin for prophylaxis of in patients with subarachnoid hemorrhage. And to conclude, these are my take-home message. These patients should be ideally taken care in a dedicated neurocritical care unit where you have a multidisciplinary team, and this should be a high volume center. Rebleeding is associated with poorer outcomes, so probably try to avoid rebleed by good hemodynamic control and early reversal of anticoagulation. And whenever the treatment decisions regarding treatment of aneurysm is made, it should be by a multidisciplinary team. And medical complications are very common. They should be appropriately diagnosed and treated. If there is a new onset seizure in patients with SAH, the treatment duration recommended is for a week. Delayed cerebral ischemia is associated with poorer outcomes. There are multiple diagnostic modalities which could be used in single or in toto, and strong recommendation is given for oral nimodipine and euvolemia for prevention of DCI. And once the DCI is set in, probably you need to do a hemodynamic augmentation, or you need to use an angioplasty or intraarterial vasodilators for treatment. And imaging and monitoring after treatment for remnants, recurrence, and regrowth of treated aneurysm is important. And you also need to have a multidisciplinary approach for and to have a discharge plan and rehabilitation, because these patients, they do have common cognitive abnormalities and behavioral abnormalities. Thank you. Sorry for overshooting, sir.
I think we'll take questions for both Dr. Shivakumar and Dr. Chaitanya. Dr. Chaitanya, please come on to the dais. Any questions for on SAH or on autoimmune encephalitis?
Yeah, sir. In the slide, I mean, I didn't mention about that, but the slides which I mentioned, where your MR is not showing you valuable information, PET addresses the issue in two ways. One, whole body PET, you see areas where there is abnormal metabolism. Second, it also helps you in screening for associated factors like any malignancy or paraneoplastic. So when MRI is not conclusive, you can straight away go ahead with PET, PET MR or PET FDG PET.
So if there are no questions, then I like